Welcome, everyone. Let's move on to a different subject, that of the bidirectional relationship between these very somatic problems that we mentioned so far and that of anxiety and depression. My name is Tibor. I work at the Institute for Pancreatic Diseases. I'm a clinical psychologist with a vision of making patient care where GI problems would be better prevented, mitigated, and then cured by psychosocial medicine. And my mission in this game would be the development of psychosocial interventions and prevention programs. But in order to do that, we have to have specific goals like everyone else. The first one would be the investigation of the prevalence of anxiety and depression in patients with pancreatitis. And the second one would be the investigation of the risk factors and the dynamics of anxiety and depression in these patients. But in order to have a general idea about these questions, I brought you a few backgrounds about this topic. What we do know, so the state of the literature is the following. We know that there is a bidirectional relationship between the brain, the gut, the microbiome, and the psychological variables. We already know that. We also know that depression increases generally the risk of chronic diseases. For example, if you look at chronic diseases and how they affect the levels of depression, you also see a connection. We see this with IBD, we see this with other inflammatory conditions. But then what's the problem, you could ask? The problem is that we do not have these data for pancreatitis, acute or chronic pancreatitis. So the question would be to provide data in order to answer this question. The clinical question then would become, what is the prevalence of anxiety and depression in patients with pancreatitis? In order to answer this question, of course, we would use a COCO-POP framework. We would study anxiety and depression. I keep using these words because these are the main takeaway messages, as you will see at the end of this presentation. Of course, we would look at the population of adults who have acute and chronic pancreatitis, with the hypothesis being that there is a high prevalence of these psychological alterations. We did a systematic review using pancreatitis on the one hand of the search and all these different mental health terms on the other hand in all major databases. We ended up with 101 eligible articles. Right now, I'm presenting the ones who have the prevalence data, and we'll continue the analysis with all the other scales and questionnaires that we found. So the etiology data and the questionnaire scores are still ongoing when it comes to analysis. What I'm going to present here, as I mentioned, is the prevalence of anxiety and depression. Now, if you look at this chart, you can see AP on the top and CP on the bottom. You can see the intervals, and also if you want to compare these results to the results of the general population, of course, there are conflicting results, but mild anxiety can be found in 14% of the population. Again, there are many studies, but let's work with that. If we see these numbers, we indeed see the population of chronic pancreatitis as a risk population where an integrated use of psychologists in pancreatic teams and services is necessary. If we move on to depression, we see the same results and the same difference between acute and chronic pancreatitis. These numbers speak for themselves. So when in 2010 and the mid-decade, we heard that psychologists need to be incorporated because maybe they can be of use in these services, now we had hard evidence, so we're beginning to have hard evidence that this suggestion is no longer a suggestion but a clinical reality. Now, the strength of this research so far was that we indeed were able to include studies and to compare them with one another that examine these psychological constructs, depression and anxiety. However, there's a very high heterogeneity in these studies. If you want to define anxiety and depression, of course, it could be expressed on a scale. Of course, we can speak about major depression on the other hand, we can speak about generalized anxiety on the other hand, and having some symptoms of these major disorders. Most of these studies didn't clarify their definition. They just used questionnaires that measured these outcomes. Also, given that we know this, there's need to be more retrospective designs and more GI psychological research that have follow-ups incorporated in them. Now, the conclusion still is that there is a considerable prevalence of these psychological alterations 2 times more often in CP than AP. Implication for practice would be, as I mentioned, revision of the guidelines. Psychological help needs to be not just suggested, but incorporated into these units. For research implications, we can say that there are dire need for prospective and RCT studies in GI psychology in order to move forward from these prevalence studies. So this is where we are right now. We are done with the preliminary data extraction. We are moving forward. The other topic that I mentioned was the investigation of these risk factors that we were talking about. In order to give you a general idea, I brought 3 questions, because this is a 3-part question that we have to deal with here. Here, what is the dynamic change of these psychological variables during acute pancreatitis? Again, we do know already that there's this feeling of unpredictability. We already know that there's a varying degree of social support for these patients. And if we want to look even more close, we can see that for anxiety, there's no significant change in the first 7 days, and depression comes and goes. So the aim would be to explore these dynamic changes of the psychological variables during the acute phase. Of course, we would use a PECO framework. It would be a prospective observational study, and patients would be assessed at admission and then every single 7 day while they are at the hospital. The second question, or even say this brings us to the second question, what is the risk factors leading to worse psychological assessment scores in these AP population? Possible risk factors are out there. We already know that what we have to deal with here is psychiatric indicators like emotional lability, stress modulators, smoking, alcohol consumption, so these negative health habits. But we need to have a look at this question systematically, not just observe the clinical data that's out there. With the possible solution being that finding the most vulnerable population at admission, we would be able to provide the most efficient psychological help for these people. This could be answered in a PFO framework with a hypothesis that psychosocial factors, I mentioned, for example, smoking, alcohol, etc., contribute to this high level of anxiety in patients with AP. And last but not least, the clinical question would be also that how do psychological assessment scores influence the clinical outcomes of acute pancreatitis? So as you can see, we started from very psychological questions and we arrived to very somatic ones. This is how 21st century psychosomatics should look like. But again, you could ask me, well, don't we have these data? Yes, we do have for other disorders and diseases. For example, if you look at this chart, you can clearly see a linear connection between patients with heart failure, there's the attributable risk on the one hand, and the prevalence of depressive disorders. Problem being, again, that we do not have these very same results for pancreatitis. So the aim would be to produce these data and see how they influence the very somatic clinical outcomes of pancreatitis. Again, that would require a PFO framework. And our hypothesis would be that unfavorable psychological assessment scores could worsen the clinical outcomes of AP. So again, these are the topics that we are working on it. And thank you for your attention, and thank you, Vance, for your wonderful questions. But please do not forget that the first wealth is health. Thank you.
Congratulations on your presentation. I saw on your second topic you have 3 questions. For the second question, what would be your answer now based just on your clinical experience?
My answer would be that we have to separate these questions for depression and anxiety, because we already know that there is no universal psychological treatment. We have to first identify who are inflicted, So first, there has to be a screening, like in every single ward where we treat these patients. And then after we are able to identify these risk populations, then we have to look closer. So it's a bit like uniting two different perspectives, one that's more general and one that's more individualized. And if you think about it, this is indeed where medicine and other health sciences are going. We have to see the big picture, and then in the end it has to be individualized. To give you an example or a case study, for example, if I think about this one patient who had high levels of anxiety, but also had some substance abuse disorder. His case is very different from that population where the drinking problem part is not present. So that's why we have to look at the broad picture and then the individualized picture at the same time simultaneously.
Okay, thank you.
Thank you for your question.
I have a question regarding your first project. Did you maybe consider subgrouping based on the age of the patients?
We are considering a quite handful of number of patients and different groups, for example, AP and CP, age, gender. We do not have answers right now, so these are in the preliminary results. But next to age, etiology is also on the table. Personally, I would be very interested in seeing the different generational differences as well, because as you can see, even the motivation to accept psychological help differs in the, let's say, older population than the younger ones. It's a very just question. Thank you.
Thank you so much.
Okay, so hi, Tibor.
Hi.
You know that I have tons of questions, but for now, do you plan using the regular scales for measuring psychological outcomes like Beck's or HADS or something, or do you have something specific in your mind, maybe, your own scale?
I do, and we do, because it's been proven that using these gold standard questionnaires is good for psychiatric wards. But when we speak about the question of hospitalization, for example, we have to have more specific questionnaires. So the HADS questionnaire that we are currently using has the same reasons behind it that you just raised, because if we compare these results, we are dealing with two very different life situations. If I have depression due to some sort of psychological etiology, those old questionnaires are wonderful. But if I have these symptoms, and I don't have to have generalized anxiety disorder or major depression, I just maybe have to spend a month at the hospital, and if I already have some sort of psychosocial problems to begin with, like what we usually see in the ward, then this is especially true.
Do you see any difference in the presence of anxiety and depression depending on the clinical course of the disease? Do you have data on that? So patients with AP can be in the hospital for 3 days, start eating on the second day and go home. And that's a very different AP from when a patient comes in, survives an ITU stay and then rehabilitated, etc. And there's also that difference in the chronic pancreatitis subgroups of patients who have got calcified pancreas but no symptoms associated with it, and then the patients who come in every other month with an acute relapse, etc.
Data are still incoming, but what I do see in my clinical experience is that they usually respond better for the anxiety treatment. Again, just a few case studies, anonymized and everything. If I think about this one patient who was able to accept the treatment and who was able to have better motivation after the hospitalization ended, he had anxiety. And I could give you several more examples of this. But if I compare this group of patients with those who had depression, that's a more difficult story. So if I compare these results with that of the literature, I wouldn't say something extraordinary. even repeat again that this is what we see in the literature. But this is the problem. We can't say that, yes, for people with anxiety, this is the case and we can't do anything about it. We have to create new sort of treatments, new sort of interventions for these people, because the regular ones or the ones that we use in psychiatric wards do not necessarily work for those patients who are hospitalized for a very different course, and psychiatric or psychological help is an adjacent one.